So please, let me know if you have any questions or if I'm speaking too fast or too slow. I trained in England, in London, and then I went to do my fellowship in Sick Kids in Toronto. And that's the picture here, which is a 3 years fellowship, but I ended up staying for 14 as a consultant. And then returned to Bristol, and now I'm in St. Mary's in London. So we are going to talk about, sorry if I can move. Yeah, so really the history of BMT is fascinating, and I think it's nice to talk about the history and understand how did this science came to light. And we talk about a little bit indication and outcome. More importantly, about half of the lecture is about the immunology of stem cell transplant and T cells and graft versus host disease, which is a fascinating topic. So the first successful BMT in human was done in Minneapolis, and I actually did a fellowship, part of my fellowship in Minneapolis. They are very, very proud of it there. It was in 1968 and 1969. And 2 cases were published back to back in the Lancet at that time. And the transplant was in severe combined immune deficiency and in Wiskott-Aldrich syndrome. So that's the first successful human transplant in 1968. And Dr. Gatti is actually still alive in NIH. But the history of BMT goes far beyond 1968. So in 1922, a scientist has actually published a paper saying that no longer guinea pigs or rabbits who are exposed to a very high field of radiation die if we shield their legs. Can you imagine how interesting this experiment is? And also, I don't know if any of you has been involved in animal studies, but it's really, really hard to get mouse and animal studies through ethics. It's much easier to do studies in human compared to animals because it's unfair. You cannot do this now, but 100 years ago, people have put rabbits or guinea pigs in high field radiation and watched the animal die after a few days. They didn't know why the animal is dying because no one knew there's a bone marrow, which is a very vital organ. And then this amazing scientist 100 years ago put a lead shielder on the leg of the guinea pig, and the guinea pig didn't die. So he thought there must be something inside that bone that prevents the death from bleeding and infection. 30 years or 20 years after that, people started to inject stem cells or bone marrow intraperitoneal. They mush the spleen of an animal and they inject it to another animal, and that prevented death after radiation. So this is the first concept of transplanting to animals. Then in 1951, that was the first time somebody said, we do not need to inject this in the abdomen or in the bone marrow. We can give it intravenously. And because these stem cells are so smart, they go and live in the bone marrow because there's signaling between them. And in 1956, that was the first time a term called radiation chimera came in history of medicine. So this is the first time we have the term chimerism. Later on, in the 60s, BMT starts in pigeons and monkeys and dogs and then in humans in 1968, as I mentioned in my first slide. And the radiation chimera word was changed into chimera because at that time, they realized that you do not need radiation to kill the bone marrow. You could actually kill it with chemotherapy. So they changed it to chimera or chimerism. But I don't know if all of you know the origin of chimera. So in our patients, when we do bone marrow transplant, when we have a donor and a recipient, we do a very important test called chimerism to see what percentage of the blood is being made by the donor versus the recipient. But the chimerism origin is actually coming from this, which is a Greek mythology monster that is a lion and a goat and a snake. So the whole idea of the term chimerism is that two people or two human beings or two lives living together. And this is the fascination of the bone marrow transplant, because once you kill the patient's immune system, you can actually introduce a new bone marrow and a new immune system. And that is the whole concept of transplant and chimerism. And the fascinating part of that, if you have a donor that is a female into a recipient that is a male, the recipient will continue to be a male. So if you do a cheek swab or a skin biopsy, it will be 46XY. But if you take a drop of blood from that patient, it will be 46XX. So a female living in the bone marrow, producing blood and immune system in a male body. And that's the fascination of bone marrow transplant. Now, currently, we understand much more and better, not everything, about what is inside the bone marrow. And the most important part inside the bone marrow, I don't know if you see the arrow, is what we call the stem cell, which I'm doing the arrow around it. This is a multi-potent hematopoietic progenitor stem cell. That stem cell lives in the bone marrow all their life. And also, there is a stromal cells here, which I'm putting the cursor on. These are the soil. So if you look at the stem cell as a seed or a plant, you need the soil for that. They need to feed, and they need to live in the niche inside the bone marrow. Now, this stem cells, obviously there are millions and trillions of these stem cells in the bone marrow. But if you take a single stem cell, they are actually a lazy cell. They are cells that are functioning all the time. And, as, we live to 90 or 100 years, they are functioning for all that time. But if you take an individual cell, they actually sleep for about 2.5 months, and they wake up for a day or two, they proliferate and make blood, and then sleep again. But obviously, there are different time points of that's happening, and then you have enough production of your blood and stem cell, and also your immune system. And when the stem cell differentiates, it goes into a lymphoid and myeloid differentiation. The lymphoid make your T cells and the B cells, which is a very important part of the differentiation, which makes your immune system, and no one can live without the immune system. And the myeloid will go and make the white cells, platelets, and red cells. It's a very, very vital organ that's hidden, but we know more about it. Now, based on what the stem cell is doing, then you can figure out the indication of transplant. I haven't put all the slides for the indication because there isn't enough time. But if you go online looking for BSBMT, which is the British Society of Blood and Marrow Transplant, you will find these indications online. But anything can go wrong with the stem cell can actually be an indication to transplant. And I'll give you an example. So the stem cell is the purple cell here that's sitting at the top, and the myeloid part of the stem cell give you the red cells, which are the red cells on the left-hand side. When things go wrong in the red cell production, for instance, somebody has sickle cell disease, or somebody has beta or alpha thalassemia, or somebody has Diamond-Blackfan disease, anything wrong in the red cells come from the stem cell. If you kill the patient's stem cell and give them a new stem cell, you can fix the red cell disorder. So that's one of the indications. Platelets is the same. There are congenital type of thrombocytopenia. The platelets do not have enough platelets, and the patients have risk of bleeding. And again, you transplant these patients by killing the stem cell and giving them a new one. And there's a whole array of white cells that you could actually cure diseases with stem cell, particularly leukemia, because cancer is a stem cell disease, and the differentiation gets arrested, then you can have leukemia. So the majority of our transplant is for pediatric leukemias to cure white cell disorders. Now, on the right-hand side of the slide, you have the immune system, the T and the B cells. And as you remember from the second slide, the first successful transplant was in a SCID, severe combined immune deficiency. These are babies who are born without T or B cells, without lymphocyte. There are a lot of genetic mutations for that, RAG mutation, Bowman syndrome, many of these mutations, but the bottom line is the stem cell cannot differentiate and produce immune system, and is incompatible with life. These are patients who are failing to fight by about 3 or 4 or 6 months, and if you don't transplant them by about a year or so, they all die. So transplant is a life-saving for these patients. So you can fix somebody who doesn't have an immune system with transplant. And also there are other conditions which are affecting the immune system, causing hyper-stimulating of the immune system, and the immune system is killing some of the patient's organ. For example, a condition called hemophagocytic lymphohistiocytosis, HLH. It's not the patient doesn't have immune system. The patient has immune system, but the immune system is dysregulated and cause chaos and cytokine storm, and for that we need transplant. So you could actually fix a lot of stem cell disorders from the immune system or the myeloid with blood, red cell and platelets and white cells with stem cell transplant. This is just to show you what we see on the slides of a blood film under the microscope. The top one is a normal blood film. You can see a lot of little dots that I'm putting the cursor on. These are the platelets, and the pink pale are the red cells, and this multilobulated mature normal cells are the neutrophils, and this is the normal blood film. On the left lower side corner, this is a patient with acute lymphoblastic leukemia. As you can see, there are no platelets, and the patient is anemic, so the red cells are lower, and there's a big blobs of cytoplasm, immature cells, which are the lymphoblasts. These are completely useless cells. They shouldn't be in the peripheral blood. They should be only in the bone marrow, and they should mature to normal cells, lymphocyte, but leukemia prevent the maturation. On the right-hand side is a slide for a child who has acute myeloid leukemia. These blasts are larger and has more cytoplasm. Let's talk a little bit about indication and how things has evolved over the years. The CIBMTR is an international center international bone marrow transplant research. Many countries around the world report to the CIBMTR. And we collect data with them. As you can see, sorry. Reporting started in the 1980s, and transplant, the autologous transplant, the blue line, and allogeneic transplant, the green line, are increasing with time. The autologous transplant is not really a transplant. It is taking patients' own stem cells, freeze it in the lab, give the patient high-dose chemotherapy in order to control their cancer, and then rescue the patient with their own stem cells. There's no chimerism and no transplant, but it's for easy terminology. It's called autologous transplant. It is mainly used for solid tumors. The dip that happened in the 90s is because many people realize it doesn't work for breast cancer and they stop doing it. But the green line is the true transplant, which is allogeneic transplant, and this is our interest. And as you can see, all type of donors for allogeneic transplant over the years are increasing because we know better about stem cell now, and we know better how to cure these disorders. In terms of indications, and as I said, for the sake of time, there isn't enough time to talk about it, but the most common cause for autotransplant in adults is multiple myeloma, which is plasma cell disorder. And the most common cause for allogeneic transplant is acute myeloid leukemia. The allogeneic is the blue, the autologous is the green. Just give you an example that in adult, auto is mainly multiple myeloma, and allogeneic is mainly acute myeloid leukemia. There's a whole array of other indications in transplant. As I said, you can fix somebody with sickle cell, or you can fix other people with that. This is a slide for the indication of transplant, the autologous on the right-hand side, but our interest maybe is in the allogeneic transplant. And as you can see, a big chunk of allogeneic transplant is a transplant for acute myeloid leukemia, almost 40%. 20% is acute lymphoblastic leukemia and other rare type of leukemias or myelodysplastic syndrome. So about 2/3 of transplants is actually done for cancer that is a blood cancer like leukemia or myelodysplastic syndrome. There are other indications for transplant, but the numbers are much smaller. For example, BMF stands for bone marrow failure, and this is 5%. Thalassemia and sickle cell disease, which is a red cell disorder, it's not, you're not doing it as a life-saving, but you are doing it as a life-changing procedure, because many of these patients with sickle cell have a lot of painful crises, and they have end organ damage, by the time they're adults. So you want to prevent that by giving them normal stem cells that give you normal hemoglobin rather than a sickle hemoglobin. But the majority of transplant is done for malignancies. In children, there are more non-malignant indication to transplant compared to adults. Particularly, these are disorders of children like Fanconi anemia, beta thal, sickle cell disease, CGD, chronic granulomatous disease, because most of these disorders are diagnosed in childhood. That's why I put it as a table for pediatric trainees. And also, Wiskott-Aldrich Chidiakigashi, which is an immune deficiency, but also an important part of transplant in children is inborn error of metabolism. So if you have somebody who has Hurler syndrome, which is mucopolysaccharidosis, the enzyme iduronidase is actually secreted by the white cell. So you actually could fix the Hurler syndrome children by doing stem cell transplant, because you're going to give them new stem cells that produce normal white cell that can give you the enzyme. So you can fix enzyme deficiency by stem cell transplant. And most of these transplants, or all of them, are done in children who are about 2 or 3 years of age. So that's why it's solely for pediatrics and not adults. And that's relevant to you as trainers. Now, a lot of people think transplant is a very risky procedure and many people die. I mean, correct. We are better now in doing transplant, but it is a complex procedure because it involves changing immune system and building immune system slowly. But if you look at the causes of death of autotransplant, the majority of patients die because of primary disease. So the transplant didn't work and the disease, cancer, has come back. In allogeneic setting, when you have a donor and a recipient, primary disease still is a big chunk of causes of death. 30%, almost 29% in unrelated, and 57% in related transplant. But there are other reasons for death, and particularly infection and graft-versus-host disease and organ failure that I'm going to talk in a minute. So it's not only the primary disease, that's the cancer or the thalassemia or the sickle cell. There are transplant complications that could happen and lead to death. And that's what makes transplant a little bit dangerous or having deficiencies. But I'm coming to the slide. What the transplant can achieve. This is a study that I did a while back, maybe about 20 years ago, looking at children who have multiple relapses of acute lymphoblastic leukemia. So a child treated with chemotherapy or radiation relapsed, and some of them relapse even again. So, in CR2 or CR3. These children will not survive without a transplant. And as you can see in this paper, we looked at two different chemo radiation protocols, but the bottom line is we could salvage about 50% of them. Without the transplant, all these children would have died. So the transplant, yes, it's a risky procedure, but there's a lot of benefit in terms of salvaging patients that otherwise have zero chance of surviving. But why transplant is better, particularly when you're talking about leukemia or malignancy? Is it because you can give high-dose chemotherapy because you don't worry about the bone marrow itself to recover because you want to kill the bone marrow? Is it because of radiation? Or is it because of something called graft-versus-leukemia effect, GVL? Now, it is because of GVL, because if high-dose chemotherapy and radiotherapy is the reason why transplant is better, then we could have done auto transplant for these patients and they survive. And auto transplant does not work, only allo transplant. So there is an evidence of something called GVL. And to understand GVL, we need to understand GVHD, which is graft-versus-host disease. So in the past, in the 50s, a lot of mouse experiments have done transplant, but the mice have died because of something called secondary disease. This is what we call now graft-versus-host disease. The bottom line is that the donor immune system is fighting the recipient. Now, this fight is very important because that gives a GVL as well, which I'm going to talk about in a minute. In 1966, a landmark paper came from Billingham, and he put how GVHD happened. And the graft must have T lymphocytes, and the host must be different from the donor. So if you have an identical twins and you do a transplant, they have no GVHD or no GVL because they are genetically the same person. And most importantly is the third point, that the host, the recipient, must be incapable of mounting a reaction to reject the graft, meaning you have to kill the recipient immune system. Does that make sense? Now, graft-versus-host disease pathophysiology is like this. Yeah, and now you can see it. When we give the chemotherapy and radiation to prepare the patient for transplant, we are actually causing damage, not only killing the bone marrow, but causing damage in the tissues of the patient. And that damage produces cytokine. The cytokine talk to the antigen presenting cells, which is the macrophage in the middle here. The macrophage cannot do anything apart from presenting it to the lymphocyte, but there's no lymphocyte because we killed the patient's lymphocyte with our chemotherapy in order to have a successful transplant. At day 0, we infuse donor cells. These are the donor T cells and the donor stem cells. So the macrophage says, yay, now I have lymphocytes. Can I present the damage that's happening in the recipient body to these lymphocytes? And these lymphocytes, that's what they do. They get activated and they get expanded, and they will give you what we call, if it's coming out, GVHD and GVL. And in the tissue, you will see apoptotic body. So the tissue is dying inside because of this T cells proliferation inside the target tissue. That could be in the gut, could be in the skin, anywhere in the body. And this is how it looks in real life. It looks a very florid skin rash. These are the donor T cells migrating to the skin and causing these rash. If this skin rash continues for a long time, it will lead to scarring. And this is one of my patients I have her consent to picture her. She has chronic GVHD and severe scarring of her skin. And as you can see, the scarring, it looks like a 3rd degree burn. So GVHD is an unwanted effect of transplant. But the issue is we sometimes need some GVHD in order to treat the cancer. What are the main risks of GVHD? And this is the immunology part of the stem cell transplant. There are many risks of GVHD, and the list is here. However, the two most important parts is HLA matching and your choice of GVHD prophylaxis, your immune suppressant. HLA, two reasons why transplant is successful now is because we are better in doing HLA matching and we are better in giving immune suppressant. But let's talk about HLA because this is the mainstay of transplant. HLA system is in the short arm of chromosome 6, and the HLA system mainly is an antigen presenting system. The HLA system cannot kill any foreign antigen. Some people believe that the HLA system is responsible for killing. It's not. It presents the foreign antigen to the lymphocyte, and the lymphocyte does the killing. So class 1 HLA present to CD8, and class 2 present to CD4. Class 1 and class 2 are the most important part of HLA for stem cell transplant because it involves the immune system. Now, how do we inherit HLA? That's very, very important, and this is the basis of us finding a donor. So when you have Homer here, I mean, we inherit it as haplotype. You don't need to read everything into it, but just look at the A haplotype. So Homer is A1, A2, and he's married to Mark, and Mark is, gosh, I can't see, it's A3 to A26, I think. So they have Bart, who is A1, A3, and his other sibling, if I can get it through, yeah, A1, A26, A2, A3, and A2, A26. So when you look at that, there's 4 possibilities of mixing and matching haplotype between mom and dad to make daughters and sons. And this is the basis of there's 1 in 4 chances of a sibling being a match to each other. But if you look at here, the A1, A3 is not a match to anyone. So none of these 4 siblings can be a donor to Bart if he needs a transplant. But the last one, by chance, is a match because he's got A1, A3. So he inherited A1 from dad, A3 from mom, and he's a match. And that could be a match to his brother. So it's not like a family have 4 children, 1 of them is going to be a match. I have families who have 13 children and none of them is a match. It's just 1 in 4 chances, 25%. And there's a family who has 2 children and they are a match. So it's just the chances. Now, based on what we talked about, you inherit haplotype. Can mom or dad be a full match to their daughter or son? It's impossible because you get a haplotype. So it's impossible to be a full match. However, if mom or dad share the same haplotype, they could be a match, a full match. So as you can see, A1, A2 from Bart now is a match to his dad Homer, but the A2 came from mom. Sorry, but the A1 came from mom because mom and dad share the haplotype, and that's called a phenotypic match. It is the second best donor. The first donor, when there's a brother and a sister, is called genotypic match. Sorry, it's too hot here in clinic. When we match for transplant, we match class 1 and class 2, 6 out of 6 for sibling, 10 out of 10 for unrelated, and 8 out of 8 for cold. These are too much details. And we don't need to talk about it. HLA matching is so important. The better the matching, the better the outcome. Now, looking at graft-versus-host disease. In the acute phase, it affects mainly the skin, the gut, and the liver, because there is more antigen-presenting cells in these organs. And we classify based on the surface area of the skin, or the bilirubin level in the liver, or the amount of diarrhea. Obviously, higher grade is a higher GVHD and more risk. The chronic GVHD has many grading systems, but the new one is mild, moderate, and severe. And it affects any organ in the body: skin, nails, mouth, eyes, muscles, liver, lungs, organs, and it causes what we call bronchiolitis obliterans in the lungs that is fatal. So it's very similar to a child with cystic fibrosis who has lung transplant. The child's native immune system rejects the foreign lung and cause bronchiolitis obliterans, and that would cause the death in transplant of the lungs in cystic fibrosis. This is the donor immune system reject the native lung of the patient and cause bronchiolitis obliterans. The same pathophysiology, and it's invariably fatal. Now, I just want to mention one pathway of the most important immunosuppression that we use for our transplant, and this is cyclosporin. It's a calcineurin inhibitor. And if you remember, I said HLA matching and immunosuppressants are the main two important factors to prevent GVHD. And I'm sure you have came across cyclosporin in your training, because cyclosporin is used for many other autoimmune diseases, such as Crohn's disease or patients who have arthritis. It's an immunosuppressant. But how does it work? In a normal situation, when you have a lymphocyte triggered by, say, a viral infection, there is accumulation of calcium in the cytoplasm and a molecule called calmodulin, and that will go into what we call NFAT, nuclear factor activating, and that will be phosphorylated. And that will migrate in turn to the nucleus. Once it goes to the nucleus, the lymphocyte, will replicate DNA and activate and expand. That's really what happens in a normal, in you and I, when we have a cold or we have an infection. That's what happens. The lymphocyte get triggered. There's influx in cytoplasm to the nucleus to replicate and expand the lymphocyte. And this is very powerful. The lymphocyte could go from 1 to 10,000 in few hours on activation to kill the virus, for example. When we use cephalosporin actually inhibits what we call calcineurin pathway inhibitor. So I'm trying to see if this is working for you. Yep. So what happened? The molecule cannot actually migrate to the nucleus now and stays in the cytoplasm, and there will be no replication of the lymphocyte. And that's the whole basis. It's a very simple, mode of action, but it's so important that it's a calcineurin inhibitor. It prevents the replication of the lymphocyte by this, and that's why it's an immunosuppressant, and it's used to treat and prevent GVHD. There are many other immunosuppressants that we use. I'm not going to talk about it. It's beyond our lecture for general pediatrics, but these are the list if you are interested to read more about it. Now, we talked about how can we cure cancer with transplant, and I talked about graft-versus-leukemia effect, which is GVL. I'm just going to talk a little bit, 5 minutes about it, just to give you an example of how important that the donor immune system actually kill the cancer cells. And that's what's called GVL. And it's been there since the 50s. And again, mice that has lymphoid tumor, when they did the transplant, they have a very important anti-tumor effect. This is a study that I did a while back looking at graft-versus-leukemia effect in acute lymphoblastic leukemia. And as you can see, the curve at the bottom, this is a relapse rate after transplant. So the transplant, if it fails or not. If the patients have significant graft-versus-host disease, they hardly ever relapse. So the donor immune system act as a checkpoint to kill any cancer cell, so they don't relapse. But if they don't have GVHD, chance of relapse is 50%. And this is really important. So GVL exists because the donor immune system is so active and robust and attack cancer cells that we cannot kill these cancer cells in our traditional way or chemotherapy because they're hidden somewhere, we don't know where, but the donor immune system can find them and kill them. And as you can see, with GVHD, there is minimal chance of relapse. Without GVHD, more than half of the patients will relapse. Another study that we looked at, patients who have very advanced leukemia, who's going to live and who's going to die. And I can show you the arrows here if you can see it on your screens. Only patients who had GVHD survived. Out of 22 patients who have multiple relapse ALL, only 6 patients who have GVHD relapse, and that means GVL exists. Also, patients, another study that we did, looking at effect of GVHD on survival after second transplant, and those without GVHD, they all die, or only 20% survive, less than 20%. Those with GVHD, 80% survive. So the bottom line is you need some GVHD as GVL, but can you do a balance? Because you do not want to give GVHD to the patient, but you want to give the patient GVL. Can that happen? Theoretically, it does. And this is the last study I'm showing you, that we looked at the lymphocyte recovery after bone marrow transplant. When you kill the patient immune system and the donor immune system starts to proliferate and increase, at day 21 and day 30, if the lymphocyte count is reasonable, they have much better chance of cure. The reason for that is that these cells will go and look for any remnant of leukemia cells inside their body and kill them. Very, very powerful. If the lymphocyte count is not good enough, the majority will relapse. And the good thing about that is that these cells, the lymphocyte, when they start to recover, CD8 and CD4, that's the cytotoxic T cells, do not recover quickly. It's the natural killer NK cells recover quickly. And the NK cells has this ability of calming things down and killing cancer without causing graft-versus-host disease. So yes, you could separate GVL from GVHD by enhancing NK cells. So we are doing that, and this is the model that many people are doing now, is that you do NK cell transplant to enhance GVL, but not to increase graft-versus-host disease. So you do not increase the toxic part of the transplant, but you improve the cure rate. Now, this is a paper that's published in Transplantation, I think about 5 years ago. GVHD think 1K cells. Now, this is my last slide because many of you might actually heard this on the news, or because it's a fashion now, which is CAR T cell. So it is type of transplant, but it's very, very clever and a smart way of transplant. You remember we talked about transplant. We take the donor T cells and the donor and the stem cell, and we inject them in the recipient after preparing them, and the donor immune system will give GVL and cure the leukemia. But also, it gives the patient GVHD and complication, and some people die. And about 15 years ago, a lot of people say, if I can educate the recipient immune system, the native immune system, to kill cancer cells, then I don't need the transplant, and I don't need to create the toxic effect of graft-versus-host disease. And that's what the CAR T cell is. We take the patient's T cells. The patient has leukemia, but we take the T cells in the lab. We put a chimeric antigen on that T cell, and then we expand it in the lab, and then we infuse it back to the patient after giving them some chemotherapy to kill the lymphocyte. And these chimeric antigen lymphocytes that are manipulated in the lab will go inside the patient body and kill all cancer cells. So really, really powerful. And the way it killed the cancer cell, because the chimeric antigen that we put on the T cell recognize the cancer cell by the antibody. So it goes and kills only the cancer cell that has that antibody. So it doesn't kill the skin or the liver and cause GVHD. Very, very smart, and that's what we call CAR T cell. And it's an autotype transplant of the patient immune system. And this is my final question. I hope in this 40 minutes or 45 minutes, I've given you sort of flavor of transplant and the fascinating part of the immune system, and how you can manipulate the immune system to cure your cancer, and also do many aspects of immunology and stem cell transplant. I am biased towards the science because this is my passion. I really like it, but I think it's a really, really nice science, and I hope some of you in the future will think about becoming a stem cell transplant, or at least hematologist. Thank you. I think we have maybe 15 minutes for questions, if that's okay.
Perfect. So there's a question for you, Adam, that says from Tom, saying, how are conditioning regimens decided for different indications?
Yeah, very good question, Tom. I mean, it's all historical. So many conditioning regimens started in the 70s and 80s, and we haven't changed them. But we know for sure that children with lymphoid malignancy need radiation. And we have just finished a randomized control study around Europe, UK, and like a global one. and there's 15% chance of better outcome with radiation in lymphoid malignancy, in ALL, but we know you do not need radiation for acute myeloid leukemia. So we no longer give radiation for myeloid. And we learned this as trial and error over the years. Now, there are actually now better conditioning regimens, what we call reduced toxicity regimens. So rather than busulfan, for instance, that has a lot of complication, there's a component called treosulfan that has less complication and the same effect. So we are better in choosing conditioning regimens, but we learned it historically.
Are there any other questions? So at the moment, I can't see any other questions. So the only thing I'd say is please fill out your feedback, and then I can give it back to Adam. And thank you, Adam, so much for giving this talk.
Not at all. Thank you for having me. Bye-bye now.
Thank you. Bye.